thank the organizers for calling here. I am going to talk about the femur interlock nailing, the routine tips in practice. Interlock nails that are available to stabilize the femur fractures and subtrochanteric fractures like cephalomedullary nails, second generation nails and retrograde nails and advanced design nails. But we need to remember that the poor surgical techniques can't replace the more advanced designs of the interlock nails. The surgical technique and steps are very important to achieve good results. First step is to have a good position of the patient, which is the first step for the success. We need to have the patient in boot traction. The central post should be kept on the opposite ischium so that the pudendal nerve palsy doesn't happen, and well leg compartment syndrome we need to observe by looking at the opposite thigh. It should not be flexed too much, it should not be stretched too much, so that there is no tension on the hamstrings and sciatic nerve as well. The correct entry point is always very important. Well begun is always half done the surgery. So a wrong entry can result in additional fractures either at neck level or at the subtrochanteric level. If you take a more anterior entry in the femur fractures, it can result in additional neck of femur fractures, which requires additional fixation. Here is a patient with a segmental level fracture. If the entry is too lateral like this, there is an iatrogenic fracture that has happened on the medial side, which resulted in gross deformity of the proximal femur, abduction, flexion and external rotation, which resulted in one more surgery to achieve union. So sometimes in subtrochanteric fractures, in long standing situations, where the abductors might have been contracted grossly, it is difficult to adduct and then derotate to get the correct entry point in the just medial to the pyriform fossa. In those situations, retrograde entry point also can be taken through the fracture site like this, and then get the correct alignment and achieve outcome like this. So the distally also we need to position the guide wire both AP and lateral view in the center of the distal femur, so that there is no malalignment of the distal segment as well. Coming to the reamers, there are two types of reamers that we need to use. First is the forward cutting reamers, which makes the path for the nail, and then side cutting reamers to enlarge the canal so that the maximum fit nail can be used, so that the stability can be achieved. So this is a cannulated reamers. It is we use a cannulated reamer or the ball tipped guide wire, and sequential reaming has to be done with the 0.5 increments, and we need to have a protection sleeve like this, so that the outer surface of the hip doesn't get reamed while reaming. So, and we need to ream at least 1.5 to 2 mm additional reaming, so that the nail can be inserted easily without any problems. So we need to have a good sharp reamers. Blunt reamers can result in sometimes thermal necrosis. We should not use a power drill to ream, and also the reverse mode, so that we don't get into problems like this. So sometimes when we use in reverse mode, there can be a problems like this, broken reamers, which requires removal. We need to have removal equipment like this curved long instruments, which can be pulled out through the entry point. And when you have a segmental fracture femurs, reaming is always an important event. Sometimes you can spin the middle segment, and it can ream the soft tissues as well. There can be splintering also, and there can be neurovascular injuries. So we need to be very careful when you are reaming a segmental femur. We need to have a derotation pin in the middle segment, so that there is no problem in the reaming. And we need to span the whole bone. We should not select the shorter length of the nail. We need to span the whole bone for proximally and distally. And then when there is a segmental fracture, sometimes determining the length becomes difficult. In those situations, before we position the patient, you measure the length of the opposite femur, and then same length of the nail can be chosen when we are doing the opposite side of the femur. So insertion of the nail also is very important. Gentle blows are sufficient. Most of the procedure should be hand driven. We should not use too much hammer, so that we can see sometimes these kind of neck of femur fractures at the end of the passing of the nail. So always we need to screen the hip at the end of the procedure, so that we don't miss any neck of femur fractures. And coming to the techniques that we can to use to achieve a good reduction. See, many times we see this kind of flexion, abduction and external rotation of the proximal fragment. So we can use a small curved artery forceps and then pass just underneath the proximal fragment using the lever against the TFL. So we can just completely external rotate, derotate it, so that the flexion gets corrected and also the rotation also gets corrected. So and when you have a neck of femur fractures like this, it is always important to do a good reduction of the trochanter by using hook reduction clamps and then small Homan onto the medial side, so that alignment can be achieved and then fixation can be achieved like this. When you have a segmental fractures with associated with the neck, sometimes the distraction at the neck of femur fracture can be problematic. So when you pass the nail, you may not be able to achieve the good compression through the cephalomedullary screws. So in those situations, what we can do is we can use 6.5 cancellous screws away from the position of the screws from the nail, like this, achieve a good compression and then proceed for intramedullary nailing, so that the neck of femur fracture is reduced well and also the shaft femur is stabilized well with a cephalomedullary nail. It is always important that we should not fracture the medial cortex just below the lesser trochanter. That is a very important bone that will save us from getting into the problems. So whenever there is a medial comminution, the nail can try to escape through the medial bone gap. So always we should not fracture the medial bone, and we should be careful about the protecting the medial surface of the bone. See, this is what I was mentioning. There is a medial bone defect where the nail can try to go into the defect, and in those situations we need to do open induction, and sometimes since the muscular forces are quite high, sometimes it can still move on when there is a large segment comminution, especially in young patients. So we might need to use two reduction tools like plate and then wires, and then we can achieve outcome like this. So whenever you have a long spiral or spiral fractures, we can use a circlage wire technique, so that we can get a good reduction before you proceed the nailing. In all the proximal femur fractures, we need to achieve the reduction first and then proceed for fixation. So, the locking screws, when you are using a cephalomedullary nail, it is always better to lock proximally and then go to the distal locking. And if the nail length is accurate, fracture is accurately reduced, then you can lock on either side also. And when you want a compression at the fracture site in a regular midshaft femur, we can use a backslapping technique after locking distally. It is always very important to look at the proximal locking screw. We should not place the screw above the lesser trochanter. This can result in, because we are reaming from proximally around 11.5 to 12 mm size, and then we are around 4.5 drill we are making in the opposite direction horizontally. This can result in fracture of the neck due to a completion of the fracture line. So at the end of the procedure, we need to check at the alignment, length and axis. We can use either cable technique or cortical step sign, like it is seen in the picture, or cortical thickness sign. We need to match the cortex both proximally and distally to achieve a good outcome. And sometimes there can be sometimes we can miss the fractures around the hip, especially when you take an X-ray like this with the thumb splint in situ. It looks like there is a comminuted fracture of the shaft of femur. Sometimes neck can be missed. So it is always important to look at the neck when we are proceeding for fixation. So sometimes we might need to change the plan. Instead of regular femur nail, we need to use the scapulomedullary nail. Whenever we have a femur fracture,
2 extra minutes to conclude.
Yeah. So, whenever you have a femur fracture, it is in abduction. Sometimes when you see an adduction, so whenever you see adduction of the proximal fragment, there can be an associated hip dislocation as well. So we need to look at the position of the fragment and then reduce the hip as well. So the success depends on correct indications, timing and technique of the surgery. Thank you.